All right, now we'll move on to the classes of antiarrhythmics. First, we have class 1 antiarrhythmics, which are sodium channel blockers. Then we'll look at class 2 antiarrhythmics, which are beta blockers. We'll talk about class 3 antiarrhythmics, which are potassium channel blockers. And then we'll talk about class 4 antiarrhythmics, which are calcium channel blockers. And we'll see a few other medications after that. Beginning with class 1. Class 1 drugs, like we said, are sodium channel blockers. What you want to remember is that there are different medications under class 1 blocking different types of sodium channels. The sodium channels exist in 3 main states. And we'll look at what they are right away. They exist in 3 main states. We have the active state. This is an M actually. The active state of the sodium channel is when the sodium channel is completely open. Completely open. We have an M gate, it's like 2 gates, and a H gate. We have an M gate and a H gate. The active phase is when both the M gate and the H gate are open. And sodium is free to move across that channel. The H gate, though, is going to slowly close. Okay, this first diagram illustrates the active state of the sodium channel. We still have some of our notes right here. We need to take out these guys. The active state of the sodium channel. And you want to remember that. All right. That's the first type of sodium channel, the active sodium channel. Active. The second type of sodium channel we'll consider is the inactive sodium channel. The inactive sodium channel. The inactive sodium channel has its M gate open. M gate is open, but the H gate is closed. The H gate is closed, meaning that even if sodium comes through, there's a barrier right there. This is the inactive sodium channel. And this channel is actually in refractory phase. It's said to be in refractory phase. The third type of sodium channel that we have is the resting channel. The third type of sodium channel is the resting channel. With the resting channel, the M gate itself is closed, but the H gate is open. The M gate is closed, but the H gate is open. This is the resting channel. The resting channel. And different antiarrhythmic medications work on these channels differently. And they all bind with different levels of affinity. They all bind the channel with different level of affinity. Class 1A medications work on the active sodium channels. Class 1B medications, and we'll see these classes in a bit, work on the inactive sodium channels. And class 1C medications work on the resting channels. Class 1A works on the active channels. Class 1B work on the refractory channels or inactive channels. Class 1C work on the resting channels. You want to remember that class 1C medications bind with the highest affinity. they bind with the highest or strongest affinity. You want to remember that. You also want to remember that at about minus 50 millivolts, I think it's the M gate. The M gate closes. While at about minus 85 millivolts, that's close to resting membrane potential, the H gate opens. Nothing too important there, just hear it and try to remember it, and that will be great. All right, let's go to the actual thing we need to bear in mind. We are going to compare the class 1A antiarrhythmic medications side by side. We'll compare the class 1 antiarrhythmic medications side by side. Right? We'll compare them side by side. All right, I think I'll need a little straighter line here. Great. So here we have class 1A, 1B, and 1C. I will see how each of them affects different parts of the heart or different types of sodium channels and what their effects are. I'll give you a simple way of remembering this. So a number of students ask me, how do I know which medication is going to be used to treat which condition? Or, you know, those type of questions. When you go to do UWorld questions many times, it looks like students don't recognize how exactly to figure out the answers. Here's something simple I came up with. And you don't have to take it as law or too standard, but it's just a general idea that will help you recall this information easily. Class 1A works on supposed normal heart. Normal heart. You say normal heart. Why are we giving medication? Normal heart means it does not have any injuries, like physical injuries to it. It may have a congenital defect. There may be a reentrant pathway, but it's a heart that is not necrotic or damaged in any way. Class 1B works on damaged heart. This is the heart of somebody with MI or somebody that has taken a lot of drugs and the drugs have damaged the tissue, like digoxin. We'll talk about that in a moment. And class 1C is used for dying heart. Oftentimes they are used as last resort, actually, when a lot of other medications cannot seem to help. Now, what is the effect of class 1A antiarrhythmic medications on the heart? If you remember, we saw our action potential, myocardial action potential graph prior to this time. We had drawn this. I hope you've seen that lecture. We saw that graph for our myocardial action potential. And we had said that phase 0, which is right here, is due to sodium, what do we call it? Influx into the cell, right? Phase 0 here was due to sodium influx into the cell during depolarization. Now, when you give sodium channel blockers, what do you expect to happen to the slope of phase 0? You reduce the steepness of that slope, and you're going to have something that looks like this. You have something that looks like this. What you want to know as well is that class 1A antiarrhythmics also have potassium blocking effect. They have potassium channel blocking effect. What does that mean? That means that this phase 3 potassium depolarization is also going to lose its steepness. It's going to become less steep. It's also going to become less steep. So when we draw this graph, we are going to have something like this. The new graph would look like this. Block sodium channels, we have our plateau over there, and then block potassium channels as well. That is what the new graph is going to look like. We block sodium channels, and it also has some inhibition of potassium channel. So remember this, class 1A medications also blocks potassium channels. It also blocks potassium channels. This could help you understand why you should have this outward movement over here. Overall, when you think of this, you have actually increased the action potential duration. You've increased the length of time it took. This is the absolute refractory period. But you've increased the length of time it took for the action potential to occur. So class 1A medications will increase action potential duration. That is one. They will also increase the effective refractory period. So if we decided to find what the effective refractory period is over here, they would also increase the effective refractory period. You want to absolutely remember that. The next thing, of course, you have to know are the medications in class 1A. The medications in class 1A. We have disopyramide. We have procainamide. And we have quinidine. Disopyramide, procainamide, and quinidine. Those are the medications under class 1A. There are mnemonics you can use to learn them. I don't know if you would find that useful. All right, so bear that in mind. The second thing you need to remember are the side effects of class 1A medications. The side effects of class 1A medications. Now, the good thing here is that each of them actually have individual side effects, and then they have a class effect. Disopyramide, for example, would cause heart failure. Disopyramide will cause heart failure. Procainamide will cause SLE-like symptoms, like drug-induced SLE. Do you remember that when people have drug-induced SLE, we have a specific antibodies that we could find in those patients, antihistone antibodies. You remember antihistone antibodies for drug-induced SLE. Quinidine, on the other hand, would cause synchronism. These patients will usually present with tinnitus, hearing loss. Tinnitus and hearing loss is basically the same thing. They may have diarrhea, nausea, vomiting, whatever, right? You want to remember that for quinidine. You want to remember that as a class effect, these medications can cause prolonged QT interval. And if you prolong the QT interval, you increase the risk of developing torsades de pointes. You want to remember that. The risk of developing torsades de pointes. There are additional things you can learn or recall about class 1A antiarrhythmic medications. You can remember that they have tendency to cause thrombocytopenia. For example, they may cause thrombocytopenia, but that's not big on the exam, right? That's not very big on the exam. And then the next thing is their use. What do we use them for? Again, we said you can use them for normal heart. So if we are talking about normal heart, when we say normal heart, what comes to mind? Maybe there is just increased heart rate. There is just increased heart rate, right? Like someone with supraventricular tachycardias. We use them for supraventricular tachycardias, SVTs. We also use them for regular ventricular tachycardias. I think we also use procainamide to treat congenital defects, such as you see in Wolff-Parkinson-White syndrome. So I think procainamide is also used in treatment of Wolff-Parkinson-White syndrome. You want to remember those. The second class of medication we are going to look at are class 1B medications. We want to see how class 1B drugs actually affect action potential. See how class 1B medications actually affect action potential. Hurry, hurry, hurry. Again, they are sodium channel blockers. So what do you expect to see? You expect to see a decrease in the slope of phase 0. But class 1B medications do not have sodium channel blocking effect, or potassium channel rather. They don't have potassium channel blocking effect like class 1A. So we have a graph that would look something like this. Notice what's going on here. The action potential duration and effective refractory period are reduced. So class 1B drugs, this is shorter than the original. So class 1B drugs decrease the action potential duration and decrease the effective refractory period. You want to remember that. The effective refractory period and the action potential duration are decreased. Basically, if you notice what's going on here, it's like repolarization is occurring much earlier. Repolarization is occurring earlier. So we could say that class 1A medications accelerate repolarization. Class 1A medication accelerates repolarization. They do not block potassium channels. They do not block potassium channels. What medications do we have under class 1A? We have lidocaine and mexiletine. Lidocaine and mexiletine. And they have a class effect in terms of their side effects. They both can cause neural and toxic and cardiotoxicity. They can both cause neurotoxicity and cardiotoxicity, right? Oftentimes it's going to be cardiovascular depression and maybe CNS depression or elevation, actually. What do we use them for? We said they are used for damaged heart. We said they are used for damaged heart. And when you think of damaged heart, what do you think about? You think about MI, right? So they're used for post-MI arrhythmias. So when you're doing your questions, they're going to give you a patient that had chest pain and whatever for more than 30 minutes and all that. Troponins are high, which of the following drugs will you give this patient to prevent arrhythmia in these patients? You want to use class 1B antiarrhythmic medications. The second thing they are used for is to treat digoxin-induced arrhythmias. To treat digoxin-induced arrhythmias. Finally, we have class 1C medications. Class 1C medications we said are used for dying heart. These guys have very little effect on action potential duration. Very little effect on action potential duration or even your effective refractory period. That's class 1C medication. Very little effect on action potential duration or even effective refractory period. So if we have a primary graph like that, when you give class 1C medications, you're just going to have maybe the first slope because it's still blocking sodium channels, but everything else is pretty much going to overlap. Look at that. Everything else is pretty much going to overlap. So there's really no change in the length of anything. No change to action potential. No change to effective refractory period, right? They have potassium channel blocking effect as well. You want to know that. They have a bit of potassium channel blocking. What are the medications under class 1C? We have flecainide, tocainide. Tocainide is like flecainide, basically, the same suffix. And then propafenone. So flecainide, tocainide, propafenone, you want to remember. The side effect of these medications may be pretty interesting because they're supposed to be antiarrhythmics, but their side effect is that they themselves are pro-arrhythmics. So you see why they're not drug of choice, really. They are like last resort most of the time. And then you want to know that these medications are contraindicated. in patients with structural and ischemic heart defects. Right? People with structural and ischemic heart defects. So if someone has MI, you are not giving them class 1C medication. If someone has an MI, you are not giving them a class 1C antiarrhythmic medication. The question becomes, what do we use class 1C medications for? What do we use class 1C medications for? We could use them for supraventricular tachycardias, but you can imagine that you're more likely to use class 1A and maybe use them as last resort, if at all. And including atrial fibrillation, you could actually use them for AFib. All right, those are your class 1A, class 1B, and class 1C medication. Remember that all these medications ultimately are actually working on your Purkinje fibers and your ventricular fibers. So class 1A medications, and really most of the antiarrhythmics you're going to be talking about, are working on your ventricular and Purkinje tissue. Basically, cardiac myocytes and its electrical innervation, right? Because we have some medications that will actually work on the SA nodes themselves and the AV nodes, and we'll see all of those eventually.